Okay, so we'll go ahead with another scenario. Your time starts now. The patient which you have treated with a combination of medication, you are reviewing, say, in 3 months' time. He had some improvement, not brilliant. His IPS score just fallen by 2. His quality of life has come down from maybe 5 to 4, and he is happy to wait. You have reviewed him again in another 3 months' time, but this time he was quite bothered with the symptoms of the tamsulosin, side effects of the tamsulosin and finasteride, and he's saying you, I'm not for the tablets, my sexual life is come to an absolute standstill. What are all the next options to try?
So I'll inform him that the next step in management would be surgery. Given that he is also bothered by his poor, given that he's bothered by the side effects in terms of sexual dysfunction, then for this man, the more realistic surgical options to offer would be prostatic urethral lift, or rasium, or prostatic artery embolization. I would still counsel him about mono and bipolar TURP and transurethral vaporization, the prostate and HOLEP, but I will offer him these surgical options.
Okay, what are all the types by which you can do TURP? Let us assume that this patient is now ready on the table, prepared, draped. Do you know any named techniques of TURP?
So there is the Nesbitt and Malmei's technique. The Nesbitt's technique consists of resecting the anterior aspect of the lobe first and controlling the arteries of flock at 1 and 11 o'clock, whereas the Malmei's technique consists of resection of the median lobe first with control of Badnack's arteries at 5 and 7 o'clock.
Okay. Any other methods you know of?
There is method in terms of the type of electricity used. So there's monopolar resection in glycine and bipolar resection in normal saline. But there's no other named methods I can think of.
Okay. What are the complications of TURP?
There are general complications including bleeding, infection, pain, dysuria, and the anaesthetic risk. Specific complications include a more than 75% risk of retrograde ejaculation, erectile dysfunction, incontinence, the need for repeat operation within 10 years due to prostatic regrowth, bladder stenosis, or urethral stricture formation. There is the risk of storage LUTS, temporary storage LUTS for up to 3 months after the operation. And then there are also the specific complications. So if monopolar TURP is used, there's a risk of TUR syndrome. If there is prior high pressure chronic retention, then there is the risk of failure of the procedure needing long-term catheterization, and there's also the chance of incidental prostate cancer being discovered in the prostatic chippings.
What is the advantage of bipolar TURP compared to monopolar?
Bipolar TURP is performed using normal saline and conduction of electricity through plasma. It allows for greater control of hemostasis, and because normal saline is used, there is less. If there's better hemostasis, there's less absorption of the irrigant fluid into the venous circulation, and therefore a lesser chance of a TUR syndrome occurring.
Okay. You mentioned about prostatic urethral lift. Just take me through what is that?
So this is a procedure which can be performed under either local or general anaesthetic. It consists of placing an implant into the lateral lobes of the prostate, bilaterally pinning the prostate back to the towards the capsule and creating a more open channel. It does not involve any resection of prostatic tissue, and it has been associated with significant improvements in terms, significantly better outcomes, in terms of quality of life and sexual function.
What is that implant made of?
So the implant is made of a nylon suture, and then there's also a stainless steel. On either end, there's one end made from stainless steel, and so one end's made from nitinol, but I can't remember what the other end is made from.
Okay. Any studies or evidence supporting prosthetic urethral lift?
The main study was the LIFT study, which looked at 3-year follow-up and where men were randomized to either Urolift or sham procedure. And this found that Urolift produced significantly better results in terms of IPSS, QMAX, and quality of life. And this was at 3-year follow-up. There is also the MedLift study, looking at the use of Urolift with the presence of a median lobe. And this did find that it improved outcomes and that Urolift could be deployed with the presence of a median lobe.
Okay. You said about resume. So what is resume?
Resume is injection of water vapor into the prostate, causing vapor ablation and vaporization. It too can also be carried out under a general local anesthetic. It doesn't require any resection of prostatic tissue, and it depends on the prostatic tissue being denatured and sloughing, but involves urethral catheterization for up to 72 hours.
So why you need to catheterize post resume?
This is because the denatured prostatic tissue will slough away and be removed via the urethra, and therefore a catheter is required in order to maintain urine drainage and not cause retention due to the retained products from the procedure.
Any evidence to support resume?
I'm sorry, I can't recall the evidence.
Okay. What is the stance of NICE guidelines for resume and prosthetic urethral lift?
So the NICE guidelines recommend that these technologies can be offered for men with LUTS that have not responded to conservative and pharmacological management, or who do not desire these means of management, and for prostates which measure between 30 to 80 grams.
Okay. You mentioned about holmium inoculation for this patient. What are the specific indications for holmium enucleation of the prostate? How it works?
So this works through an anatomical enucleation, so separating the prostate adenoma from the capsule, and it's indicated where the prostate size is more than 100 grams. It can also be indicated where there is acute urinary retention, or if histology is required if there is suspicion of prostatic malignancy, in the whole context of LUTS as well.
So how do you do holmium enucleation?
This is performed under a general anesthetic. It's performed using a holmium light YAG laser. It's a 550 micron laser fiber with a maximum power of up to 120 watts. It consists of separating the adenoma from the capsule, and the prostatic tissue is then removed from the bladder by means of a morcellator.
Okay. What other energy sources can be used for anatomical endoscopic enucleation of the prostate?
For enucleation, a thulium laser can also be used.
Any other?
In terms of laser operations in the prostate for laser vaporization, there is also KTP laser, KTP green light.
Okay.
I can't remember any others.
Okay. What do you know about vaporization of the prostate?
So vaporization uses KTP laser, which has a wavelength of 532 nanometers and a penetration of 0.8 millimeters. It is recommended in the NICE guidelines for prostates which are between 30 to 80 grams. With vaporization, there is a lot less bleeding and a lesser chance of retention, but no tissue can be obtained.
Okay. Is there any group of patients where you prefer laser-based surgery compared to TURP or any other methods?
So in terms of specifically holmium enucleation, this would be if the prostate size is large, so more than 100 grams. In terms of laser enucleation, to reduce the risk of bleeding, this could be in comorbid patients at high anesthetic risk.
Okay. We have completed the time, but we will finish with one question just for completion. What do you know about aquablation?
Sorry, I can't recall that.
Okay. Yeah. So how do you do, Piyush? Any feedback from you before I start?
I think I've focused a lot on the BPH theory, so I've probably let the surgery. So I think the surgery I'm at a basic level to pass, but I would like to kind of know things a bit more in detail, especially about. I think I knew UroLift reasonably well. Rasium I need to read more about, and POLEP I think I know kind of well.
No, again, I'm very confident, Piyush. There is nothing really to worry. You are perfectly in line. If you just reproduce what you said today, that's more than enough to get the marks closer to 8. But as you said, maybe a little bit beefing up here and there since you have time and since you have crossed the necessities. This is more of like a topping up to get the best out of the exam. The main advice I will say is I have passed through so many slides in this video recording. So in the YouTube, just sit comfortably and every time there is a slide change, try to go back to the slide and try to read what is in the slide. I may not be able to give you a feedback of whatever I am showing in the slide in words. That itself will take another 1 hour. So that is a very good resource, and at this point with another 10 days to go, I don't want you to waste your time on any other resources. Just only the slides which we are going to add in the YouTube link is more than enough. Okay. Regarding the TURP methods, Nisbet starts from 12 o'clock and there is another method known as Brand's which starts from median lobe and from below. So Brand's median lobe resection and then from below to up, while Nisbet's is 12 o'clock and above to below. So in Nisbet's, indirectly we are not tackling the Alcock or Flox vessels first. So we are coming to them quite late. Because when you explained, you mentioned in Nisbet's we try to treat the vessels and get hemostasis before going ahead. It's slightly different. Okay.
Again, the Malmaise technique I described, is that?
Malmaise is fine. So there are 4 types you can say: Nisbet's method, Alcock's and Flox method, Brand's method, and Malmaise method. Nisbet's fine except for the fact it starts from 12 and up down. You can say Alcock's and Flox method. That's the exact thing where we deal the vessels first before going for any other thing. And Brand's method is from below to top. And when you're explaining the complications of TURP, you can divide them broadly into short term and long term. Short term are the one like reversible things like dysuria, catheter related problems, etc. While long term are the one where patient can develop urethral stricture, etc. And when you come to the bipolar's advantage, there are some studies comparing TURP with monopolar with bipolar, and the studies shared like less catheterization time, less irrigation time, less operative time. I mean, all the studies were a little bit skewed to support bipolar because it's new in the market, and studies were also market driven. But even for the exam, if at all, if you have to say what is advantage of bipolar versus monopolar, rather than just saying the mechanism how the bipolar works and safety in the presence of like metal objects or pacemakers, you can also rope in the studies to prove that it is good from intraoperative and postoperative point of view. And the prosthetic urethral lift, the capsular concept is made up of nitinol. The urethral plate is made up of stainless steel, and the interconnecting is the PET suture. Lift study is a 5-year study. You said 4 years. And you can also bring in BPH6 study, which is a very good supporting study for prostatic urethral lift, because it is a randomized controlled trial comparing prostatic urethral lift with TURP. You said lift study, you said mid lift study, but BPH6 study is a equally very high weightage study. You mentioned in resume it can be done under local anesthesia or general anesthesia. Local anesthesia with prostatic block like transurethral or transperineal, they're all not very good. Patient still feels pain and discomfort. So in normal practice, most of them end up having like a sedation or complete GA. So don't try to say local anesthesia for resume, but it's good for prostatic urethral lift, local anesthesia or completely without any block we can do. The reason why we keep catheter after resume is because of the injection of the steam, the prostate will swell up. So already there is a occlusive prostate lobes, and it will further swell up, resulting in complete blockage at least in the immediate postoperative period. That's why we are keeping the catheter. The sloughing of the prostate tissue won't happen in general. In general, it should happen like convective energy transfer of the radio frequency waves, and the gland should apoptosis and shrink rather than shedding out the tissues. The shedding out the tissues, and that's the reason for the catheter placement. That's not the correct way to approach. It's more for preventing the acute urinary retention, and patient can have to walk maybe in 3 to 5 days time. Anatomical endoscopic enucleation of the prostate can also be performed by using bipolar technique, bipolar energy source. There is a specific type of loop for that, a little bit good stern metal box like loop, which can be used to lift the prostate. On the whole, anatomic endoscopic enucleation of the prostate is a technique by which you are enucleating the prostate in its anatomical plane away from the capsule and pushing it into the bladder. And then you are using the Moser-Later to take the prostate out. That separation, when you are doing, you don't need anything. But if you are in the correct plane, if the patient had no previous history of UTI or prostate biopsies, the whole thing can be done in a very athermic manner. But if there is a vessel, you need something to get the hemostasis. For that, we can use holmium or laser or bipolar. Any energy source, the outcome will be equally good. So the man behind the machine is more important than the actual machine itself. Having said that, holmium is very good in coagulation compared to thulium, and compared to thulium, bipolar is a little bit inferior. So it is only marginally, but if a man behind the machine is good enough, with bipolar we can have the same outcome as holmium enucleation. The main advantage of any laser based surgery, whether it's a laser based enucleation like HOLEP or thulium enucleation, or laser based vaporization like green light vaporization, they are very good for patients on antiplatelets or any anticoagulants. Even though we have to stop them adequately, the chances of bleeding complications are much less in the coagulated patient compared to any other procedures like, say for example, resume or TURP, where the patient adequately stopped the anticoagulants. Know a little bit about aquablation. I'm not sure about the future of aquablation because the uptake is little bit poor and it takes long time for the general use. It is an image guided robotic water jet ablation. So it uses the hydrodissection to ablate the prostate parenchyma and sparing the collagenous structures like blood vessels and surgical capsule. A very high velocity saline ablates the prostate tissue, creating the channel, and it's completely robotic in operation. You are using a transrectal ultrasound to monitor this in real time. The only problem is after completion of ablation, patient needs a Foley catheter for appropriate hemostasis, or sometimes we may have to open up a laser or TURP to get appropriate hemostasis. That's the main concern. The advantage of this is good for larger prostates. There are two studies, easy to remember. Aquablation, aqua means water, so the studies are water 1 and water 2. As usual, water 1, they recruited patients only with smaller prostates up to 30 to 80 ml, while water 2 they recruited larger prostates with 80 to 150 ml. Both are multi-center studies and international studies, and both got 12-month outcomes, and overall aquablation is good for even larger prostates, while you can't use resume or prostatic urethral lift or iTind or any other sources. Know a little bit about iTind and prostatic artery embolization. Lack of time in the 10 minutes, I'm not able to ask you the questions in that. iTind is still in a research stage. NICE guidelines have not approved iTind to be used in day-to-day practice unless if you are covered by a clinical governance and appropriate audit. It works almost like Urolift, but the whole 3 prongs of the iTind will be removed in 5 to 7 days. The period in which the iTind is in place in situ, it is a bit of challenging for the patient and also to the surgeon, can cause significant dysuria and storage symptoms. Prostatic artery embolization, again we have the UK based rope study, but unfortunately we need to have the involvement of the good dedicated interventional radiologist, and it's good for patient to presenting with a large prostate not amenable for an appropriate TURP or enucleation, where you want to do something without subjecting the patient to an hours of surgery. But the disadvantage is patient will end up having so much of radiation, and if the patient, elderly patient especially, if there is atherosclerosis, sometimes the vessels may not be quite amenable for appropriate embolization. The whole concept of prostatic artery embolization arose from the embolization practice of fibroid uterus, the same techniques. So learn a little bit about that, because sometimes if your examination card has a little bit of weightage on prostatic artery embolization, that will be useful. Again, if you go through the YouTube link, the slides what we have made is more than enough actually.
Yeah.
Good. Any other questions from you before we complete today?
No, I don't think there's any other questions.
Good. As usual, we are available anytime till you finish the exam. So just send a message whenever you have any burning question which you can't find a quick answer, just to save your time, so that we can help you by finding the evidence or appropriate answer. And as I said, this video, please pause and go through every slide. It will be like a single point source of all the answers for the BPH table. You don't have to waste your time referring anywhere. Okay?
Great. Thank you.
Very good. Best wishes, and hopefully I should be able to do one with you within next 24 to 48 hours. I will message you.
Okay, great. Thank you very much.
Very good. Have a nice rest of the day. Bye.
Bye-bye.